We're live.
Okay.
Welcome to Unremarkable Labs. We have a special treat tonight because we have a very well-known guest, Dr. Reza Menash from the, is it the Sepulveda VA?
No, the West Los Angeles VA.
West Los Angeles VA, and one of the founders of Clinical Problem Solvers, who's going to help us discuss this case. As usual, our president, Dr. Natasha Mehra, is here, and my former intern from 2 weeks ago, who's now a second year, Dr. Andrew Girard, he and I are going to sort of present the case and then talk about how we went through the case. This case starts in a very interesting way. And on day 3 of the patient's hospitalization, he's a 71-year-old man. Andrew tells me that he just started Lokelma because the guy has a potassium of 5.7. Now, one of the reasons that I found this fascinating was recently there was a major thread on Twitter from a critical care doc who said he didn't want to know about the potassium, that just let the house staff take care of it, and you know, it was never important, which I didn't respond to very well. And then just this week on Twitter, Reza posted something, says the most important thing in medicine is knowing the answer to why. And so I'm going to let Reza ask Andrew questions about the patient so we can start to figure out why this patient has a potassium of 5.7. And I can give you the rest of his numbers here if necessary.
Would it be fair to say that I don't want to know about the ABG? I let the house staff take care of that. I am just joking.
You can say anything you want to.
I am joking. First of all, thank you so much for having me and for the invitation. I am so excited to go through this case because there's never been a case that I've discussed with Uncle Bob, and especially one that involves electrolytes, where I don't come out as a better diagnostician. So for all the audience listening to this, pay close attention because I promise you will be better because of the hour we spent together. And really, before I ask Andrew any questions, I'm just going to share my basic approach to hyperkalemia, because once you establish an approach, the approach allows you to ask hypothesis-driven questions or perform a hypothesis-driven exam or collect hypothesis-driven labs. So when I approach hyperkalemia, the first question I ask is this hyperkalemia real? Just to give you an example, Uncle Bob, 2 weeks ago, we had a patient who was very difficult in terms of collecting blood from this patient. And they would struggle. I actually was in the patient's room and it took the phlebotomist 30 minutes to collect the blood. And so when the blood resulted with hyperkalemia, the immediate reaction was, let's act. But in this patient, the cause of the hyperkalemia was actually in vitro hemolysis. Many labs will report this in the lab thing. So the first question I'll ask Andrew is, could this be in vitro hemolysis? One way to verify that, if the lab doesn't report it, is to send an AST, which is ubiquitous in all cells. So when you have real hyperkalemia, you will also see an elevation. I apologize. When you have false or in vitro hyperkalemia, you'll also see an elevation in the AST. So Andrew, was this hyperkalemia real?
It was real hyperkalemia. So we had called down to the lab and they said that there was no hemolysis.
Very good. And I do have to just include a very brief point here is that sometimes when you do have hemolysis, you do have to distinguish between in vitro, meaning that they shook the tube too much, or it was a difficult puncture, versus in vivo hemolysis, which can certainly cause hyperkalemia. Another point for the pseudo hyperkalemia is you want to look at the white cells, the platelets, because they can cause the K to be high. As the blood clots, the K will leave the cells. Andrew, the CBC, was it normal, or was there any extreme leukocytosis or thrombocytosis?
No, so there was no severe leukocytosis. His white count was 8.2. His hemoglobin was actually low. It was 10.7, and his platelet count was 232.
Okay, very good. Thank you. So step one, is it real? So here we're dealing with real hyperkalemia. For step two, I actually asked myself, do I need to obtain an EKG? As much as it pains me to admit, sometimes management is more important than diagnosis. So when you have a K of less than 5.5, I don't rush to get an electrocardiogram. Anytime I get north of 5.5, I do obtain an EKG, but it's important to note that you might not have any changes on this EKG until something bad happens, especially when you get to levels of 6 or beyond. And an easy way to remember the changes on EKG is imagine someone's pulling up that T wave. You get peak T waves that are painful to sit on. You get widened QRS, widened PR interval, and the atrial cells are more sensitive to potassium than ventricular cells, so you may lose P waves. Again, this is, I would categorize this as just mild to moderate hyperkalemia, not severe. So Andrew, my next question for you, do you have an electrocardiogram?
So we did not collect an electrocardiogram on the day that the potassium was measured at 5.7, because we presumed that the hyperkalemia was chronic in nature. But he did have one on admission, which was normal sinus rhythm.
Okay, very good. Now, we asked, is it real? We don't have an EKG, that's fine. Step three, you have to perform a base rate approach to hyperkalemia, meaning you got to start with the most common etiologies. And those include the creatinine, the medication list, and what is the patient consuming? This is a real story. I had a patient whose creatinine was improving, but their potassium was worsening. This makes zero sense. And then I got to the patient's bedside and there was 2 liters of orange juice, which is high in potassium. So Andrew, my question's for you. What's the kidney function currently? But remember, labs aren't binary in nature. You said this potassium was chronic hyperkalemia. So I'd want to know, what is the kidney function? And because Uncle Bob's on this recording, I want to know the muscle mass. I won't end at creatinine. I would want to know make sure that the muscle mass is there. I'd want to know the trajectory of the potassium and the creatinine. I'd want to know the medication list. And I would make sure that the patient doesn't have 30 bananas at the bedside with orange juice.
Sure. So those are all great questions. So at baseline, his potassium is around 1.4, or I'm sorry, creatinine is 1.4 to 1.6 over the last few years. His potassium has been chronically elevated around 5.1 to about 5.6, and the max potassium 2 years ago of about 6.1. And it's kind of bounced around within that range. In terms of muscle mass for this gentleman, he appears like a chronically ill person. So he has a little bit of muscle wasting, mainly in his extremities. And that's kind of what you can see. And in terms of bedside, when I was there every day, I did not see any orange juice or any high potassium food products.
Fantastic. And can we get his medication list?
Yeah, absolutely. Let me pull that up for us real quick. Okay, so on admission, this guy took amlodipine, he took aspirin, he took atorvastatin, he took carbidopa, levodopa, he took cetirizine, he took chlorthalidone, cholecalciferol, he took iron sulfate, He took fluticasone. He took insulin glargine. And he took Senna and Miralax and sertraline.
It might be worthwhile to now tell you why he was admitted to the hospital, because it's just going to put a slight different flavor to all of this. Because when he first came in, I think his potassium was around 4.8, and then it went up. So it's an interesting story. So Andrew, why don't you go ahead and talk about why he came into the hospital?
Sure. So he was originally had just come home from his nursing home. And his brother had taken him in. And while he was at the house during the next day, his brother had noticed that he was not acting himself. He wasn't responding to questions. He had a fixed gaze deviation to the right. He was just overall seeming very confused to his brother. And that was very concerning to the brother. So the brother took him and brought him to the VA hospital for further evaluation for a chief complaint of confusion.
And in the emergency room, he tested positive for
COVID.
And then over the next 2 days, his neurological symptoms improved back to baseline.
Correct. His neurologic symptoms improved back to baseline. He had a neurology evaluation. They said even if there was something neurologic going on, he was outside the window for intervention. So overall, he improved back to baseline, received dexamethasone inpatient for his COVID. And then that gets us to hospital day number 3, where I draw the labs and I say, hey, we have a high potassium. And I go talk to Dr. Centor and I say, well, I've ruled out this cause. I don't know what this could be. And Dr. Centor asks, why do you think his potassium is elevated?
Would you like the rest of the electrolyte panel?
That would be great. Thank you.
I can give that to you. So on hospital day number 3, the rest of the electrolyte panel, the sodium was 139. The chloride was 105. The bicarb was 22. The BUN was 43. The creatinine was 1.5. The glucose was 129.
And Andrew, if I can ask you one more question.
Sure.
I know you said that the potassium oscillated between 5.1, 5.6 over the preceding months. But if you were to graph like his creatinine versus his potassium, when he was on the higher end of normal, was that when he was having a creatinine that was north of 1.5? I'm just trying to get a sense of how much of this is from impaired, kidney function.
Kidney function. No, that's a great question. I did not graph the potassium and the creatinine together. Dr. Centor, did you happen to look at that?
Yeah, I looked at it pretty carefully, Reza. He would all of his creatinines since 2020 were 1.4, 1.5, or 1.6, and it'd go up and down without, and seeming like a random walk. Similarly, his potassium would go up and come down and go up and come down. He'd had many hospitalizations. He had significant underlying neurological problems and had at least one stroke.
Okay.
And so he'd been on the neurology service quite a few times.
Okay.
No one had ever evaluated his hyperkalemia that we could find.
Got it. Okay. All this is super helpful. And I will tell you, I learned from Dr. Joel Toff's book on electrolytes that in order to have persistent hyperkalemia, you have to have some form of kidney insufficiency. It must be present, because if the kidneys are functioning well, even if you have cellular release of potassium or you take in a lot of potassium, you'll excrete out the excess potassium. So let's talk about the additional history. So I think when someone is coming in confused with a focal neurologic deficit, it becomes really important to try to find or evaluate for a potential structural lesion that's causing the neurodeficit and the confusion, as opposed to just confusion, which is much more of like global pathology of the brain, where we think about metabolic, infectious, and toxin-related processes. So this patient gets diagnosed with COVID, gets started on some dexamethasone, is improving, and then we find that once again, the patient is slightly hyperkalemic, but no one ever asks the question, why is the patient hyperkalemic? So you look at the medication list, and here Andrew provided us the complete med list. And looking at this, it seems that the patient has hypertension. So medications like chlorothalidone, if they don't cause kidney injury, we often see them cause the electrolytes to go down, whether it's the sodium and the potassium, based on their mechanism of action. So this patient's on chlorothalidone and is still hyperkalemic. Glargine, actually, insulin pushes potassium into the cells. So the patient is receiving glargine, I don't know how many units,
10
and
units.
it's still high. Oh, go ahead, sorry.
10 units, sorry.
10 units. So the patient is receiving glargine. Chlorothalidone, so glargine pushing K into the cell. Chlorothalidone getting rid of K. Then the patient was also on laxatives, I believe you said, Andrew, Senna, right?
Yes.
And that would cause K to leave from the GI tract. So despite being on all of these therapies, the patient is still hyperkalemic. So it sort of speaks to the degree of hyperkalemia that we're dealing with, which seems disproportionate to the degree of renal insufficiency, though you have to be cautious. You have to be cautious. I say be cautious because it seems like the patient has Parkinson's, has muscle wasting, and at this stage, maybe it's more end stage, and so may not have a very high creatinine. It may have, very advanced kidney disease. But what could happen during the hospitalization that could lead to hyperkalemia? So now we're applying a schema 2.0 of hyperkalemia, 2.0. So you already listed 1.0, which is kidney function medications. 2.0 is saying, is there something happening with the ability of the kidneys to excrete the potassium that's not just renal insufficiency? That's really the next layer of the hyperkalemia pyramid. At the peak of the pyramid is cell lysis, but we're not there yet. We're at the middle of the pyramid. And this is where you have to think about aldosterone. So what does aldosterone do? Aldosterone acts on the nephron to increase the ROM-K channels through the mineralocorticoid receptors, and that allows potassium to be excreted, sodium reabsorbed, and hydrogen also excreted. With aldosterone, the most common cause that you have impaired aldosterone action is because of medications like ACE inhibitors, ARBs, ARNIs, aldosterone receptor blockers. Less common causes, but probably applying in this patient, is a type 4 RTA. When you have low renin because you have kidney disease and the juxtaglomerular apparatus isn't releasing renin well, you won't have as much aldosterone. So hyporeninemic type 4 RTAs. Within the hospital, you always have to look for heparin. So if the patient's getting hospitalized, if they're getting heparin, this patient had COVID, so presumably was on pharmacologic prophylaxis, and because of the kidney injury wasn't given enoxaparin, so probably was given heparin sub-Q. Heparin can block aldosterone from binding to the mineralocorticoid receptors. So I would be curious, Andrew, is this patient on heparin sub-Q?
Yes, we did put him on heparin 5000 TID for prophylaxis.
So that's one possibility. I would actually, you have to then weigh, and if you're really concerned that the heparin is causing it, but the patient's hypercoagulable, then it's totally reasonable to say, hey, I'm going to give Lokelma, though you have to be cautious with the sodium in Lokelma. It can cause edema and hypertension. I'm going to give Lokelma while knowing that it's probably the heparin. Once the patient's discharged, I'll check another potassium in the outpatient when they're not on heparin and see what the potassium level is. With regard to adrenal insufficiency, you don't need to have hyponatremia for adrenal insufficiency, but I want a little more like fatigue, abdominal discomfort. There's not much going for it, though. It's a very tricky diagnosis to make. So if you really are working up hyperkalemia and you've gone beyond the base rate of renal insufficiency and medications, you have to consider primary adrenal insufficiency where you actually lose aldosterone secretion. I'll pause there to let Uncle Bob navigate me.
Yeah, so we weren't worried about adrenal insufficiency because he was on dexamethasone. So we felt like we were treating that. What I recommended was to get a urine potassium and a urine sodium. And we can give you those results. And then I know how I interpreted it. I want to hear how you would interpret it. His urine potassium was 31 and his urine sodium was 62.
Okay, I will, I'll tell you the general idea of why we send these tests. In general, whenever you have an abnormality like hyperkalemia, because we know that one of the main possible sites where pathology exists is the kidney, you ask the question, is the kidney behaving appropriately or not, right? You have a disturbance. Are we doing proper homeostasis? So in the ideal world, if you're hyperkalemic, you should have an increase in potassium excretion if the kidney is not contributing to the hyperkalemia. So this is referred to, I believe, as a transtubular potassium gradient or something like that. I often don't calculate it. You might get a spot potassium because usually hyperkalemia, you can identify based on the history. So Uncle Bob, to me, it just looks like this potassium is not high enough, but that's the question I would be asking or putting into MD Calc. If the patient's not having a lot of K in the urine, then I know the lesion is at the kidney as opposed to, transcellular or, the patient ingesting too much.
Yeah. So the way I interpreted it was in the face of hyperkalemia, aldo should be stimulated and his urine potassium should be higher than his urine sodium. He should be holding on to sodium. And so this was implicit evidence that he was hypoaldo. We do a very similar thing in someone who has cirrhosis before we start spironolactone. We get a urine sodium and urine potassium, and in that case, we find a high urine potassium and a low urine sodium, which tells us the patient has secondary hyperaldo. So it's not the absolute value, but the relative values that point us towards that. Now, the question is, so the question we asked is, he has an estimated GFR of 52, given his age and his creatinine. And he's had diabetes for at least 8 years and probably longer. So we were thinking about hyporenin and hypoaldo, but that's way too high a GFR. So how do you reconcile that?
Yeah, well, I mentioned at the beginning of this that I would learn something, and I'm going to take this pearl of the urine potassium, expecting it to be greater than the urine sodium if the kidney is doing what it should do. One thing I'll say, Uncle Bob, is that I just am a little perplexed because the patient also has low muscle mass. So in this patient, I would send a cystatin C to get a better understanding of what the kidney function is. Because it's just so easy for me to say someone has kidney disease, CKD, gets put on heparin because they're hypercoagulable from COVID, and has hyperkalemia because they're vulnerable to hyperkalemia because their kidneys aren't working properly.
Right, but we knew that he'd had hyperkalemia multiple times in the past without heparin. So what did we do, Andrew?
We obtained a
cystatin C, and 3 days later it comes back.
Yes.
Because it's a send out.
And it was approximate, I believe it was 2.56. Is that right, Dr. Centor?
It was actually 2.65, but that's close enough.
Oh, okay. Which equates to an eGFR of around 20.
So your instinct, which is a great instinct, and one that too few clinicians have in 2022 and too few house officers have is that the clinical presentation did not make sense for his estimated GFR from his creatinine. So we got a cystatin C estimation. And instead of this guy being stage 3A chronic kidney disease, he's really stage 4 chronic kidney disease. And that totally changes how you think about this guy. And so that's really the bottom line of this story, is that this guy really has very severe kidney disease. And so he actually needs to be seeing nephrology to think about what they're going to do next. Andrew, why don't you share with Reza the lessons that you felt that you learned from taking care of this man, and then we'll let Reza give us sort of a wrap up of what the take-home points should be for everyone who watches or listens to this.
Yeah, so if you have an isolated laboratory abnormality or even a few laboratory abnormalities, you have to ask why, and you have to be able to try to tie those things together. And I think that was one of the biggest things that I learned in this case, is not overlooking any of those things, not just saying, oh, I'll put them on Lokelma and move on with my day. It's actually taking a step back and saying, wait, is there some underlying pathology here that could be affecting my clinical management down the line? And clearly here, as we see, we now know that his CKD is worse than what we originally thought, and that's going to affect his clinical management later down the road. And then in terms of just keeping a broad, thinking about a mental schema for hyperkalemia. So, as you mentioned, is this real hyperkalemia? Is this pseudo hyperkalemia? Or is this, true hyperkalemia in the sense of, is the patient taking too much potassium in? Or are they having an impaired ability to excrete it? Or is this a transcellular process where potassium is moving between cells? And so having that mental schema, I think, provides a good way of thinking about your patients. And that's the two big things I think I learned.
So Reza, you did beautifully on this one. And certainly, well, because it was similar to the way I thought about it, I think you were perfect. But what do you take home from this case that you can apply to your residents and or people who listen to this when it's released?
So actually, Andrew, when you were sharing your teaching points, I got goosebumps. Why? Because you have an incredible mentor, advisor, clinical role model, but that's not enough, Andrew. I can't tell you how many times where I've tried to teach something and the learner doesn't emulate. So I just want to applaud you for recognizing the teaching point Uncle Bob was making with regard to asking the why and really internalizing it and making it one of your main teaching points. So that was just a beautiful, teacher, trainee, and internalization. Thank you for that.
Of course.
And then I do have to make a confession to the audience. So you heard Uncle Bob say I did well on this. But if I hadn't met Uncle Bob years ago, there's no way I would have done well on this specific case. So Uncle Bob calls me every couple of weeks and he teaches me what he learns and pearls. And so I just want to put that on record. If you didn't get this diagnosis or if you didn't think about the cystatin C, you need an Uncle Bob in your life. And then as far as like what I'm going to take with me and apply it clinically and teach my learners is this urine potassium and urine sodium. Like I've used this for SIDH and to see if fluid restriction would work or not, but I hadn't used it before in the context of hyperkalemia. So that's one learning point that will sort of, make me better going forward.
And Natasha, you always get the last word because you are the queen of Unremarkable Labs.
So I have a short story about always asking why as well, and it'll be an Unremarkable Labs case at some point. But I worked with Dr. Centor over the week of Christmas, my intern year, and we had a patient who came in with a simple, or what we thought was a simple heart failure exacerbation. But he had his labs didn't make sense to Dr. Centor. He had me repeat his bicarb and his VBG a couple of times. And we ended up looking into it and realized that he actually had a respiratory acidosis, I think, that he was trying to compensate for by blowing off CO2. And so I think that's one of my biggest learning points too, asking why and making sure to not just kind of peruse over any lab abnormality and at least consider why. And even I think the biggest thing that he taught us was it doesn't have to be on the call day, because sometimes you're admitting 8 patients and you're really busy, but don't forget to go back the next morning and look back and see if you missed anything. So I agree that Dr. Centor is a great mentor and can teach everyone a lot about acid base. Cystatin C is a lab that I have not ordered myself, but I actually just listened to a podcast. I think it might have been maybe Dr. Centor's podcast about it and it being a really useful test, especially with all the debate about race calculations going into GFR. So I think it's a great test, and I think this is a great example of why we should be using it more. And I think it's great that the VA has it.
Yeah, the VA just got it this year in Birmingham. It is a send out, but it came back in about 3 days. And Robbie's here. He missed all the excitement, but Robbie, I can tell you that Reza stood up tall throughout the entire case. Would you like to say hello, Robbie?
Hello, everyone. I'm still here in the ER. I have took care of an incredible case that I can't wait to share with all of you in the near future. I'm not the least bit surprised that Reza stands tall. He's a towering giant of clinical wisdom and excellent skincare. I don't know if he has his video on. I actually can't tell. So yeah, I'm not the least bit surprised. Prof. Rez.
Robbie, I miss you so much.
I miss you too. I can't wait to tell you about this case. It involves a fever with incorrect origin is the title. Not unknown, incorrect. I promise you'll all hear about it.
Well, to everybody who's watching this on YouTube, thank you so much for joining us. And hopefully this will also be released by the Clinical Problem Solvers in a podcast.